And basically the four categories, or the way I'm classifying these approaches, are as follows. One is an approach that I think I've heard described here, which is that for the formal sector, we have explicit contributions. For the poor, there's going to be budget subsidies, fully subsidizing their coverage, and everyone else has to contribute. Okay? A second option that we see is simply to fund coverage for everyone who's not in a formal Social Security arrangement from general budget revenues, so that anybody who's not in a formal scheme is automatically entitled as a consequence of citizenship or residence. A third approach is guarantee certain services for all. So in a sense, take a path towards universality, not by getting more people into a scheme, but actually defining certain services that would be available for everyone. And fourth would be to look at ways of complementarity between direct contributions and government budget subsidies. So first, I'm going to talk about the first option, which I think a lot of people are thinking through, which has to do with these unsubsidized contributions for the non-poor informal sector. And theoretically, this has certain advantages. I mean, it should be pro-equity in the sense that it's meant to be about taking contributions relative to people's ability to contribute. It minimizes the fiscal impact because you're not taking any additional revenues from the central budget. And again, as we heard, it should not have any impact of diminishing the formalization of the workforce. It would really be a means to try and formalize the informal sector. So it has these advantages. From an international perspective, it has one very important disadvantage, which I'll highlight here, which is that it's just never worked anywhere. So this is a drawback that you may need to think about. It's also, I think, quite costly to implement because, again, of this boundary issue, the need for very narrow targeting, and some of the revenue collection things that were discussed this morning are really quite a challenge in such a large country. So this is an issue to think about, a completely unsubsidized participation, because in effect, it is really like a de facto, even if it's legally compulsory, in practice it turns out to be voluntary, and it's very difficult to implement. So, well, that's as I said here. I mean, one of the challenges, and this happens in a number of countries that we see, is that in many ways the government has been unable to collect tax revenues from this part of the population. But we in the health sector think we're going to be able to do a better job than the tax authorities. And it's not clear that the evidence that the evidence for that is quite strong. It's not the specialization of the health sector to be in the revenue collection business. So this is an issue and a challenge. And again, I said it becomes de facto voluntary, and it's very costly to implement. So the conclusion is that it has some theoretical advantages, but it won't work to go this way. It will leave a large number of currently non-poor people at risk. They may become poor as a consequence of this because they won't join, or they won't join until it's too late. And so going with this approach and saying, well, we'll just make sure, even though every other country has failed, we're going to make sure that they all contribute, is not realistic. I promised I was going to try and keep people awake after lunch, so this was something I would try for. So an alternative to this might be seen as the other end of the scale, which is to fully fund coverage from general budget revenues. So we're going to have a presentation, I guess, tomorrow morning from Thailand. You're all familiar with that. We know in Mexico as well, they've both taken the approach of saying we will just simply not try to target at all, and say for anyone who's not in a formal Social Security scheme, will use general revenues and everyone will be enrolled. In fact, both of those countries began with the intent to collect a small premium as well from the population, but they gave up, saying it wasn't worth the cost of collection. This does have certain advantages, that it's, especially compared to trying Target, it's much simpler administratively. You don't have additional revenue collection costs and so forth. It can work. We've seen there is experience of that. And Indonesia has an advantage relative to Thailand and Mexico on one sense, which is that you're not talking about a separate scheme. This is about including everybody in the same scheme, this grand, largest single payer in the world. So in Mexico and Thailand, they have not been able to unify the approaches, but it seems like you have the political will here to do that. Of course, it's not that easy, and it has challenges. As I say, certainly the fiscal situation, and we heard that this morning, that the fiscal constraints are quite tight. And that's a problem, and it may also, and there's been evidence from both Mexico and Thailand, that one drawback is that it may contribute, or at least reduce the rate of formalization of the workforce. So those are challenges as well. I want to focus, though, on the implementation issue, and I'm going to take a slight detour into the issue of fiscal context and fiscal capacity. Because at the core of all of this is what is the ability, as well as the willingness of government to spend on health from its budgetary resources. And in part to keep my card, I guess we would call it, as an economist, I have to put up an equation, and this is the simplest math, or the most complex math I can do, which is a way of thinking about what actually explains in any given year government spending on health. And as I show here, if you look at the equation, that government health spending as a percent of GDP is the product of two things. One might be called the fiscal capacity of a country, which is saying what is total government spending on all sectors relative to GDP. So how big is government in the economy? And that times the priority that the government gives to health. So of that total government health spending, how much is devoted to health? And I want to just show you some data, and whenever one puts up data, it always lends itself to challenge. I will say these are our latest available data in our global health expenditure database, which is for 2011. And of course, situation in all these countries may have changed. But just to give you an idea, and really looking at Asia, Indonesia, compared to the rest of the world. And this chart shows total government spending as a share of GDP. So it's around this overall fiscal capacity. And what this is saying, I don't know if I have a pointer here, but in any case, the bar across the top is showing the average per country globally. So on average across the world, governments are spending about 34% of GDP. So public expenditure overall is 34% of GDP. That's not health, that's total government spending. Indonesia is half of that. That one, okay, good. Does this make a big difference? Okay. So Indonesia is half of that global average. And as you can see, Asia is quite small. Asia has relatively small public sectors compared to the rest of the world. Okay? So you could say here that while Asia has a limited fiscal capacity, Indonesia is quite constrained fiscally. The overall size of the public sector is small. Now, in terms of priority, let me see if I can. The priority, again, is this is, regardless of the size of the public sector, what share of public spending is devoted to health? And here, as I'm saying, Indonesia is at the extreme for the world, not at the extreme for Asia. But on average, countries around the world spend between 11 and 12% of public spending going to health. In Indonesia, it's only 5.3%, which in 2011 was the 10th lowest in the world. And so when economists, when we're told very often that in many countries that health is a priority, we say, well, let's look at the numbers. And at least here, the numbers don't seem to match the rhetoric around health being a priority. Now, these may have changed, of course, but this is a starting point that's very difficult. So the product of those two things, the fiscal capacity times the prioritization, left Indonesia in 2011 with a very low level of public spending on health as a share of GDP, less than 1%. And again, you can see how Asia overall is quite low relative to the global average, which is only about 4%. And that's government health spending as a share of GDP. So in that equation, and I'm just going to show some illustrations to make a point about what might be possible. This is just a few countries I've selected from that chart. And again, in that equation, so you've got, here's the fiscal capacity of those countries, and here's the different priority that they gave to health, which together results in what government health spending as a share of GDP was. So from this, what you can do is say, okay, fiscal capacity is a bit outside of, it may be outside of our control. There are aspects of the economy that we can't easily manage, and unless there's some radical change in our ability to collect taxes, we're kind of stuck with the low level overall of fiscal capacity. But priorities, that's clearly a political decision that we can make. And so in this, what I've done is saying, imagine all of those countries had the same level of fiscal overall public spending as Indonesia, but with their, or put it another way, that imagine Indonesia with its overall level of fiscal capacity had the other countries' priorities. In this column here, and sorry, I don't know if this is too fast, but this is what public spending on health as a share of GDP would have been. So if, for example, with Indonesia's fiscal constraint, if they had Thailand's prioritization, instead of 0.9% of GDP, it would have been 2.5% of GDP. China, again, so you can see these different areas. So, yes, fiscal capacity matters, but priorities matter as well. And it matters because from what we know from global experience, that there's a very clear relationship between what governments spend on health and what people have to spend out of their own pocket. So in this graph, it shows basically here's government health spending as a share of GDP, and this is again 2011, and this is out-of-pocket spending as a percent of total health spending. And according to the data, Indonesia was about 50%, but you see it's at a very low level of public expenditure, and in general, there's a trend that the more governments spend, the less people spend out of their own pocket. There's also a lot of variation around this trend, which is very good for me, because without that I wouldn't have a job. It would just be an accounting problem. But in any case, this matters. And so while this option is, you could argue, and I would argue, is very easy to implement, this option of simply fully funding from the budget coverage for everybody who's not explicitly in a formal social security scheme, we can say a couple of things. One is, certainly from an international perspective, it appears that Indonesia has the capacity to spend more on health. The government does. Not because there may be some big change in fiscal capacity, but clearly the prioritization of public expenditure could shift to get closer to international averages, let's say. And again, this would seem to be appropriate given the rhetoric, and I have my button here somewhere, that if we love universal health coverage, then we need to show how much we love it. But even with this, given the state of the fiscal situation, it may be that the realistic level, even if the prioritization share doubles in 10 years, it might only mean getting up close to about 2% of GDP as public spending on health. And that's still quite a low level by international standards. So, there's a real question of whether that would be adequate for going completely with this option. It's not clear that how far, there's certainly scope for increase, but whether one could fully fund a package from this level of public expenditure is still uncertain or unlikely. I don't think it's been done at that level of public expenditure on health. Okay, so that was a long tour on that, and again, that option was about simply forgetting about contributions entirely from the informal sector and fully funding from general revenues. Now I want to take just briefly a third approach, which is not talked about much, but might have relevance here. And it's what I call, there's no label for this, and I did make this up, I don't know if it will stick, calling it stepwise progress and selective universalization of services. I don't know how that translates. But basically what it means is to take, rather than trying to get more and more people into a scheme, maybe an alternative is to get more services available for everybody, but not recognizing that you can't get all the services available for everyone. So in a way to expand coverage via services rather than population. And what it would mean is that you've got an explicit kind of inequality. I mean, it exists now that, some people would have, everybody would have something, but some people would explicitly have more than others. So there is certainly an equity issue in the transition part. But it could be quite in line with priorities and capacity, and in increasing the scope of services that is available to all. So the example I was using is from one of the countries of the former Soviet Union, which is Moldova. And I didn't realize at the time that, at least in percentage terms, certainly not in absolute terms, but in percentage terms, they're in a very similar situation in terms of the extent of population coverage. They use payroll tax contributions, employers and employees. They have a large informal sector. They have a lot of targeted subsidies for the poor and so forth. And the latest data we had from 2009 showed that they had about 72% of the population covered and 28% largely informal, non-poor, uncovered. Very similar here. What they decided to do, yes, they're continuing to make efforts to try and get people to contribute, but they took a decision at that point to say, we will universalize primary care services. So not the same package as everyone else, but they had in their budgetary revenues, they're already providing a lot of budget to the system, that said, we're going to make a decision to universalize primary care because we think not only is this a good idea for health reasons, but also can help us manage costs as well. And the mechanism was really kind of built into the provider payment system, that they had a capitation payment mechanism for primary care that was driven by the number of insured enrolled people in each primary care practice. And this effectively changed the basis for that. They put more budget money into the system and changed the basis for that capitation to just the number of people enrolled in each primary care practice. So it was possible to introduce this mechanism of expanding certain services for everyone, while still it left a gap, of course, that this 28% does not have the coverage for the specialized care. So this is another possibility. This is something to consider, reflecting a public commitment to at least something for everyone. In the panel this morning, I kept hearing the point that it's practically October, and January is almost here. And it occurred to me, well, this is something you can implement tomorrow. So in a way, as it's obviously not that easy, but in terms of you're already developing things like the capitation system and so forth. So this is at least something to consider in terms of moving forward. It would have to bring a more explicit budgetary commitment. But again, as I showed in that previous set of slides on the overall spending, that would seem to be feasible. It would also reduce the amount needed for premiums for others when collecting, because you're already collecting certain services from this. And of course, it's easier to implement than a contributory-based affiliation to the insurance scheme. The risk is whether this gets stuck and that you create this kind of a permanent two-tier arrangement, or if it's just seen as a step in the process of a universal and unified benefit package for everyone. Okay. So the last option, or the last approach I'm going to talk about, is what I call a combination, which is subsidized participation with a strong public commitment to universality. So this would incorporate and increase the reliance on general budget transfers, but also retaining contributions for people outside the formal sector. Now, we've seen in high-income countries that have contributory-based entitlement that general budget revenues still play a key role. So in Japan, for example, 25% of the revenues of the health insurance system come from general budget transfers. In Hungary, over half of the revenues of the National Health Insurance Fund come from general budgets. And Germany has increased budget transfers into the system. So they're all combining the budget revenues with the contributions in various ways. So this is not some odd, arrangement. It's something that we see in many countries that rely predominantly on contributory-based entitlement. It is still a de facto voluntary participation in countries that have low tax capacity, even if it's subsidized. And we do see in many countries here, even if we get low participation, you get high dropout rates, it's still difficult to draw that boundary and maintain, who has to pay a bit, who doesn't pay at all, and so forth. And most countries really don't reach high coverage through this route. But there are a couple of examples of countries that do, and I want to at least explore some possible reasons why that's the case, as maybe some food for thought and seeing what might be applicable to Indonesia. And these are countries that are very different in size and geography, which is China and Rwanda. And I think they bring out certain lessons, although again, one can never replicate fully all the environment, and especially the political environment. But they've each achieved about 90% or more, and I understand in China it's more, coverage with their voluntary schemes. One thing, what I would pull out as common reasons why. One is that the cost of the premium is much less than the perceived value of the benefit. And so people, it really stimulates willingness to pay, in part because people are quite aware in those countries of the consequence of not being insured because of the high out-of-pocket payments. But the premiums are quite subsidized both on the supply side through the direct subsidies provided to healthcare providers, and also on the demand side in various ways that the premiums are matched or otherwise supported from public revenues. Second, and very important, and I think extremely important in the case of Indonesia, is a very strong and explicit role for local government in the process of making this work. It's not just between the health insurance fund and the people. There's very strong action at local level. They have very strong incentives or instructions for local officials to get people into the program in both countries. And in China, anyway, local governments are obligated to commit premium subsidies as well. So this is important. And the third point is probably the part that's not replicable and perhaps not something you want to copy, but certainly one reason that might limit the the ability to generalize from these experiences are those of both very strong governments who are able to instruct or guide or force local authorities to do certain things. So one needs to obviously keep that in mind and not suggest that it's going to be possible just to copy those methods. But I think some of the principles are worth looking at. And again here, one is that the premiums are not set according to some actuarial calculation. They're set on the basis of affordability. Because again, the point is not to make a surplus for the insurance fund. The point is to get everybody included. So the approach of how one would do this in a private market is different than how you would do this in a public insurer. So there are very strong and explicit roles for budget subsidies. Second is that certainly the prioritization for health has to increase, but it may simply, given the fiscal situation, it's unlikely to be enough here to be able to fully fund the system just from that, in addition to the formal sector contributions. And so it looks like you're going to have to go with this idea of some type of complementary funding mechanism. But again, you know that better than I. One thing that I think might be very important, and sorry, here, just to say that here, it's in this second point about China, that there's a very explicit link that when somebody contributes to their health insurance scheme, that triggers a subsidy from both local government and central government. So there's this very clear link, and government is clearly buying health insurance for those people. And that, I think, is useful in terms of thinking about, again, the accountability for the use of public resources. And again, at the end of the day, in both countries, it's clear to a lot of people, and I think you pointed this out, that there's not a lot of information out there, or there's strong information gaps about coverage options. In those two countries, people are quite aware, I think, that the expected benefits of buying into the scheme for most people are worth, the costs, again, because of these features. Local governments, again, have very strong roles. In Rwanda, they have a mayor in each district, and part of the pay of the mayor depends on the extent to which they get people enrolled in the insurance program. China also uses strong mechanisms for local officials who are going door to door to get people into the program. So I don't know what those mechanisms could be here in Indonesia, but important to think about what the role is for local government. So just to conclude on this option, it might be very relevant, again, for Indonesia, given these points about the fiscal capacity and the need to think about complementary funding. The third point we find in many countries is that typically it's not enough for the Minister of Health or people from the health sector to tell the Minister of Finance how important health is, because everybody else is telling the Minister of Finance how important their sectors are. I think what's interesting, for example, in what China does, and thinking about that as a possibility here, is to be very explicit in the dialogue with Ministry of Finance that you're kind of leveraging private contributions, that part of this program is that for every rupiah that a person puts in, you will match that or more than match that with a public funding commitment. So it would be very clear what government is buying with their resources, and that might be an easier sell in terms of being transparent in what's being given. It's not just giving more money to the health facilities. That might be needed, but this might be an easier way to sell the argument. And finally, and very importantly, a strategy without a very clear, defined role for local governments won't be enough of a strategy. This is really critical to making whatever you choose to do at the policy level, making it work. So keeping people informed, encouraging participation, possibly subsidies if that's a role that you could see for local governments, that has to be very important. Okay, so just to conclude, first of all, and while I've talked a lot about money, if the level of spending was enough to get you to universal coverage, then my country would have had universal coverage a long time ago. So it's really about keeping focused. And it's not the case that, even where spending is low, efficiency is less important. That's not the case. You can afford less waste than other countries. So paying close attention to managing resources wisely is critical. Being able to match any request for additional funding to being able to say how the money is going to be used, very important to make a credible case. And as I said, the example I was just giving might be one way of thinking about that. And really what you want in this process is you don't want your single fund to be so focused on revenue collection that it forgets about its primary role, which is purchasing services wisely on behalf of the population. So they should not divert their attention into the revenue collection agenda. So to summarize, and I don't know if this is too bright in here, last messages. I think you're in a very good position where you are now. The approach of a single fund with a common package is an excellent starting point. It shows really political ability to overcome the fragmentation that characterize the current situation and characterizes so many other countries. The other countries have not really been fully able to overcome that in many cases, but it looks like you have an agenda to do it. Second, the priority for health and public spending has to increase, or this will be an empty promise. So reaching the informal sector and saying, well, they all have to contribute, that's not going to be enough. We need to think about how to use budget transfers, how to use local government in the implementation as part of the process. Those all have to be part of the new strategy. And then again, lastly, to make sure that you're partnering any request for more funds with a very clear promise of accountability for how the money is going to be used, a focus on efficiency, and basically then being able to demonstrate afterwards through the, for example, the public reporting mechanisms that will be put in place for the new fund, to show the government and the population, most importantly, how the money is being used. And with that, I'm done. Thanks very much.